Hello, my name is Dr. Lauren Legacy-Frost, and I am very thankful for the opportunity to present a recording for my presentation due to some unforeseen family circumstances. I'm grateful to be here. It's been a long journey, and I'm thankful that we were able to have the conference and find ways to attend. Again, my apologies for not being able to be present live tomorrow. So what I was hoping to do was share my screen and go over and talk about the project a little bit. So what I have here is essentially a culmination of reflections. I started as an ICU nurse, as an associate degree ICU nurse, and I began to notice this phenomena that as I went through my education, my sort of path to academia, I now realize that that's what we do as nurses. We tend to identify phenomena at the bedside. So that's a lot of the work that I did with my doctoral education. But when I reflect back and I think about this project itself, it really started when I was an associate degree nurse in the ICU. And I was noticing this ongoing phenomena of certain patients being readmitted into the intensive care unit. And that struck me as very interesting. It struck me as interesting on a personal level, just thinking in regards to, what is this like for the patient, obviously? What is this like for their family? The time that they're out of work, if they were working. And then you start thinking of the greater and broader spectrums in regards to their community and things of that nature. Granted, at that time, I wasn't thinking that broadly. I was more just thinking, oh, here's so-and-so again, and they're being admitted again for another COPD exacerbation or diabetic ketoacidosis, congestive heart failure, things of that nature. Unfortunately, what we now know, and again, I was not very familiar with then, but what we sort of now understand as being these chronic conditions and dealing with the end stage of those in the ICU. So as I went through as an associate degree nurse, I earned my bachelor's degree while in the ICU as well. And then I started to really pull more strings together. I started to understand a little bit more about the socioeconomic status and people's communities and how that affects our overall health. So in doing that, I decided, well, I think there's more I can do. At that point, I had been in the ICU almost 5 years, so I was almost an expert in that field. And I felt that there was enough that I had done there, but that there was more work that needed to be done. So I went on for my master's degree, and I went on for my master's as a family nurse practitioner. And what I did with that was I took sort of this foundation. I was this novice nurse thrown into an intensive care unit. I had this phenomena of these frequent readmittances for the end stages of common chronic diseases. And so what I built on was I said, well, I'm going to be a family nurse practitioner. And now that I understand socioeconomic status and communities and preventative health a little bit more, I'm going to devote myself to public health, community health, and I'm going to work in a family practice office. And I'm going to prevent Mr. and Mrs. Jones from having to be readmitted for these exacerbations of their chronic conditions. So I went off with my purpose and I earned my master's degree of nursing, became a family nurse practitioner, and I practiced in family practice for about 8 or so years. Again, was identifying phenomena. I was able to help more, and I was grateful and I was thankful for that. But there was more of this folks struggling with these chronic diseases, how they were impairing their quality of life. I had far more opportunity in a family practice setting to really kind of delve in and chat with folks and get a pretty good understanding of what their lives were like and what obstacles they were facing in their healthcare. Reflecting back, I think, often we may take it for granted if we don't pause for a moment, sort of our various expertise and our various understandings of health and healthy choices and lifestyle modifications. So it was really wonderful getting to be a partner and a peer with folks with our shared goal of improving their health. I was very, very fortunate. But again, identifying this phenomena of these chronic conditions affecting quality of life and, again, folks being admitted into the hospital or the ICU because of these exacerbations. Well, I felt that I did a pretty good job there. I was really able to help folks and really loved that my position there. I still thought, again, 6 or 7 years in now, maybe there's more that I can do. At that point, I was thinking more, again, another step out. I went from the ICU to an outpatient office, and then I was noticing the community. I was thinking to myself, what can we do in the community? How can we help change and improve these situations for folks here? So I went on to earn my Doctor of Nursing practice because I thought this is where I'll really be able to help. So that's what leads us to my presentation. I appreciate your bearing with me as I shared a little bit of that history, but I really believe that as we sort of reflect back in our evolution on our personal paths and then our evolutions with our peers and our cohorts, that if we can think back to our foundations and where we came from, there's just a lot that we can pull forward. So what I chose to do was an education for folks in family practice because I was still working in family practice at that time. So we developed an education intervention to prevent sedentary behaviors in the adult family practice population. So this took place in a rural, very rural community family practice, and it took place with willing participants via survey. So what we talked about here, what the literature reviews went over, was that obviously we understand that chronic diseases are a significant concern. And in my sharing of my story, I just felt that that really showed, these chronic diseases from our quality of life every day all the way to frequent ICU admissions, which is what we're all really trying to prevent folks having to deal with the hardships of that. So we identified in literature reviews, of course, that sedentary behaviors have really been red flagged as being contributors to chronic disease. So again, I'm looking at people's communities, I'm looking at their homes, their lifestyles, things of that nature, and the increase in sedentary behaviors is something that we've really noticed. I'm sure you're familiar with the Robert Woods Johnson Foundation, things of that nature, and they are doing so much community-based work for things just like this. It's really wonderful to read what they're up to. So there's a distinct underlying physiology that prolonged sitting actually has an effect on the body, and it inactivates the lipoprotein lipase, and then it has impacts on that lipid metabolism. So essentially a slowing down, which with sedentary behaviors, I suppose that would make sense. But as we all know, we need to be moving. We need those highways to be clean and clear. And that is why we are always recommending exercise. So that's what the purpose of this project was, to really try to hone in on what can we do in our communities to help prevent this alteration in lipid metabolism. So let's see, what the goal is to reduce uninterrupted sitting, as we believe that this may improve overall health. The current knowledge gap is providing a need to develop effective interventions. So within the literature review, the gap of knowledge that we had available was this. We sort of identified, okay, we think sedentary behaviors are causing this alteration in lipid metabolism. We don't yet have evidence as to what to do to improve that or change that. So identified that gap, and then tried to think of, okay, what interventions, small baby steps, little community-based interventions are we able to do here? So the purpose of the project was to identify patient interest, always trying to get the buy-in, understand your audience, to learn more about sedentary behaviors. Again, time and family practice, sort of starting to recognize that folks were living their lives and making their decisions, but didn't quite have that knowledge or education as to what were the healthy decisions to make. So how do you get that buy-in? How do you get folks to want the education on how to make little tweaks to their lifestyle to improve their overall health? That was a little bit more challenging than I had thought it would be. So that was one tier of a two-pronged approach. And then the other part was to develop a tool to help reduce sedentary behavior based on the feedback of patients who were interested in this. So the methods, we had a convenient sample of 20 anonymous adult patients. Now this is very interesting because there were thousands of folks who were invited, and we had 20 positive responses. So I think that just harkens back to what we were just discussing in regards to, folks have to be interested in obtaining the information that you would really want to present to them. So a primary care practice completed the baseline needs assessment survey. So based on that, an education tool, based on what was selected, they were given options. How would you like to be able to learn about different lifestyle modification behaviors? It was a website, a pamphlet, a brochure, a podcast, things of that nature. And folks voted on having a website. So a website was developed, and the tool was validated using the system's usability scale, and then it was reviewed by the experts, as you can see their credits below, experts for the content of it. So then the results, you can see there in regards to the voting of what folks put was a preferred medium for learning. And then we have the standard usability scale results. And expert consults. Now, I was really fortunate. I had a doctor of physical therapy. I had a fitness trainer expert on my team. I had another doctor of nursing practice as a mentor. I had someone in my practice itself who was my cheerleader. And then I also had a doctor of nursing science, pediatric nurse practitioner also, who was able to help me with this project. And so what we found was we needed to really further define the medical terms into a more user-friendly format. I had an identified muscle group, so that was something that we decided would be really helpful, because helping folks identify the names of the body and how that's going to benefit. So the implications of the project were giving primary care providers a patient-preferred tool. So a tool that a select group of patients within a large rural family practice population wanted, a tool that was a website, and allow them to decrease sedentary behavior, therefore helping to reduce the chronic disease in a primary care population. Bringing it back out, helping to reduce ICU admissions would be the main goal. So the intervention was a website, and it was called stopsedentary.com. And what this website did was it went over a variety of stretching that folks can do to break up sedentary behaviors. So it gave an allotted amount of time that the body can be sedentary, but then it recommended that folks get up every so often, about 15 to 30 minutes, again, depending on associated comorbidities, and then perform a round robin series of stretches. Just stretching this way, it's movement, it's again cardiovascular, but we were able to find things that met the vast majority of people's abilities. And so the website was decided to be a success, and then we had the feedback. And then the next step in this would be to run a pilot and actually have patients participate in a survey utilizing the website, and then cataloging at how they're feeling 2 weeks out, 4 weeks out, etc. So again, I appreciate your taking the time to listen to my presentation. I am very sad that I'm not able to be there in person. I was really looking forward to enjoying this experience with you all. I appreciate your time, and please reach out if you need anything, and thank you for listening. I hope you all have a wonderful day. Thank you.